So thank you, sir. So respected chairpersons, respected seniors and dear friends. So after all these excellent surgeries, now I am going to discuss on a topic which is a most dreaded complication for cataract surgeons, and none of us want to have this. Even a TAS is also very dangerous for all of us. We had recently all the experiences of TAS, no financial interest. As you know, hello. So acute post-cataract surgery endophthalmitis usually presents with 6 weeks of intraocular surgery. There is always invasion of globe by microbes, bacteria or fungi during cataract surgery. Now whatever may be the treatment, 15 to
Audio team, there is some noise coming up here.
So this is a very serious complication of cataract surgery and is considered as an ophthalmic emergency. So etiology, mostly in sporadic cases, contamination occurs from patient's lid and ocular adnexa. So there are chances of aseptic protocols and faulty surgical techniques. And in cluster endophthalmitis, most of the time it is from sterilization failure or contaminated surgical supplies. So there are possible risk factors explained in the literature, starting from diabetes, advanced age, immunocompromised condition, adnexal infections, then contralateral prosthesis. Intraoperative risk factors can be application of 2% Xylocan previously used for topical surgeries, prolonged surgery, clear corneal incision is a risk factor, secondary IOL, posterior capsule rupture, vitreous loss. Silicone IOLs are found to have more prevalence of endophthalmitis. Contaminated irrigating solutions, visco and trypan blue. Post-operative there can be because of wound leak or vitreous incarceration. So organisms, it is found that coagulase negative gram-positive staphylococcus is the commonest. Next is the Staphylococcus aureus and streptococcus. Emergence of methicillin-resistant staphylococcus are a major problem now because they are resistant to even fourth generation fluoroquinolone. Enterococci resistance to cefuroxime. So gram-negative bacteria in 5% of cases, mostly Klebsiella and Pseudomonas. So endophthalmitis has to be differentiated from TRAS, which appears on the lid edema is not common in TAS. So there is limbus to limbus corneal edema with TAS and patchy corneal edema, and there are certain differentiating features. So we have to differentiate between TAS and infective endophthalmitis, and it is always to err in the side of endophthalmitis than with TAS in case of suspicion. So now what I want to highlight is the NPCB guidelines for prophylaxis, because the prophylaxis is more important than treatment in those cases. So NPCB guidelines recommend all patients should be screened to ensure patent nasolacrimal duct and negative regurgitation test. Syringing not to be done on the day of surgery. Adnexal infections to be treated with systemic antibiotics. Lid conditions, sac-related conditions to be treated first, and intraocular surgery delayed by at least 3 weeks after these surgeries. Avoid contact procedures on the day of surgery. Like contact biometry also should be avoided on the day of surgery. Then pre-operative and operative precautions are topical antibiotics. It is advised 4 to 6 times, at least 1 day prior to surgery. Bath of patient, head bath and face wash before surgery. Periocular skin to be cleaned with povidone iodine 10%. Intraocular instruments and cannulas not to be reused. Disposables are to be used wherever possible. OT to be washed before use and surfaces carbolized. Gloves to be changed after every case, and scrubbing and gowning to be done after every 5 to 6 cases where there are multiple cases posted for the same day. Post-operative precautions, subconjunctival antibiotics with steroids are advised. Single drop of 5% povidone iodine in the conjunctival sac after completion of surgery. Systemic antibiotics if adnexal infections are present. Topical antibiotics post-operatively with anti-inflammatory or steroidal agents has to be advised. Personal hygiene to be emphasized. Routine weekly, if necessary more frequently post-operative visits should be ensured. Frequent installation of eye drops to be. So these are the post-operative instructions that are to be ensured. So topical 5% povidone iodine, as we have all know and convinced, that has a protective role. Intracameral antibiotics Maybe, may not be, there are controversies, and still it is better to use in case of topical surgeries where subconjunctival antibiotics is not possible to give or should not be given. So it should be considered as an emergency, and management has to be started with intravitreal dexamethasone and broad spectrum antibiotic as soon as possible. Repeat injection is required if the condition remains persistent or there is worsening. So in fulminant refractory endophthalmitis, early vitrectomy is advised. So basing on the presenting vision, treatment algorithm has been advised. So the tips is adhere to proper OT sterilization protocols, mostly prescribed by NPCB, because that is to be used in case of medical legal cases. Pre-op ocular examination is very important, 5% povidone iodine, at least 3 minutes. This is very important, staying of povidone iodine for 3 minutes contact time. Meticulous draping of lids and lashes, attention to watertight wound closure, vitreous incarceration to be treated, intracameral injections, early follow-up, compliance by the patient, and intravitreal antibiotic and prompt referral are to be advised. Thank you, sir. Thank you very much.
Yes, a very wonderful presentation for the concise one. So there, especially for the cluster endophthalmitis, there is a media trials. So how to avoid that media trials and how to deal with that? It's very important nowadays.
The first thing is patience. We have to have patience and try to find out the cause and explain in a very clear term what has been done or what has not been done. My point of presenting this is, if you are following the protocols, then there is less chance of wearing, because we cannot 100% avoid endophthalmitis in any situation.
Then how do you deal the counseling, post-op counseling for this? If some patient develops infection, so how you start you break the news for the patients? Any particular protocol you follow? How you break the news to the patients? Because sometimes, patient gets anxiety with this one.
That is correct, but most of the time, if you are very honest to the patient and you have a very personal relationship and rapport with the patient, they understand the things.
Yeah, because many times I have seen that sometimes doctors don't disclose that you have developed infection.
No, that should not
they will
be
say,
done.
no, you have developed some inflammation. Or they will
Yes,
use like term
once
like
you
that.
avoid the patient, they will have lot of suspicion and there will be problem.
Yes, sir.
Thank you very much for bringing out the various aspects of endophthalmitis. Indeed, a good